Hello everyone. Today we'll be talking about mitral stenosis. Now stenosis by the name suggests that there is something narrowing. So by definition, this disease is a form of valvular heart disease which is characterized by the narrowing of the opening in the mitral valve. So with any disease in medicine, we start with its definition, then we move on to the etiology. So etiology of this disease is mostly the acute rheumatic fever. Most of the patients who present with mitral stenosis are usually ladies who in their early stages of life have an infection of acute rheumatic fever, and now it has presented in the form of mitral stenosis. So the most common etiology here is acute rheumatic fever, and therefore the most commonly it occurs mitral stenosis most commonly occurs in which patients? Female patients. Second most important cause is the congenital MS, that is congenital mitral stenosis. Third is left atrial myxoma. Fourth is autoimmune diseases like systemic lupus erythematosus and rheumatoid arthritis. And fifth is calcified mitral valve. You should avoid using this left atrial myxoma in the etiology because most of the teachers do not consider it as an etiology, rather they consider it as a complication. So you can avoid here it. Similar is the case with infective endocarditis. So these are the important causes. You should say about the acute rheumatic fever most commonly, then congenital MS, then these autoimmune diseases and the calcified mitral valve. These are more acceptable. Then we come on to the pathogenesis of this disease. So this disease is characterized by chronic inflammation of the with diffuse thickening of the valve leaflets. So you have the bicuspid walls, the tricuspid walls. On those walls, especially the mitral valve, there is diffuse thickening of the valve leaflets, and then there is formation of the fibrous tissue over there. Now this fibrous tissue, what does it forms the contractures. So commissures and chordae, they fuse and they shorten, and when they fuse and shorten, they lead to the appearance like known as fish mouth appearance. You can see the fish mouth, it is very narrow and it seems like it is being contracted from all the other sides. So it happens like that. So this appearance, that is fish mouth appearance of the valve, is very important finding. Then there is calcification of the stenotic valve. So already narrowed valve gets calcification on itself, and that further immobilizes the stenotic valve leaflet, and that worsens the stenosis. Now this can further lead to thrombosis and thromboembolism. So now we move on to the severity of the mitral stenosis. According to the AHA guidelines, that is American Heart Association, the normal valve area of mitral valve is 4 to 6 centimeters square. So now if it is mild, the valve area is more than 1.5 centimeters square but less than 4. Moderate, it is 1 to 1.5 centimeters square, and less than 1 centimeter square is severe mitral stenosis. Similarly, on the basis of systemic pulmonary artery pressure, you can also categorize it into mild, moderate and severe. Mild is less than 30 mm of Hg pressure. 30 to 50 mm of Hg pressure is moderate, and more than 50 mm Hg pressure is severe. Similarly, mean pressure gradient in mm of Hg also less than 5 mg, then 5 to 10 mg, and more than 10 mg. So this way you can classify the severity of this disease. So now let's come on to the clinical features. The most common presentation that is being shown here is the dyspnea. Now when you will be asked dyspnea, you will be asked about the NYHA grading of dyspnea. The NYHA grading of dyspnea goes like this, like grade 1 is dyspnea when you do heavy level of exercises, like you run a lot or you do some heavy weight lifting, then you get dyspnea, that is grade 1. Okay, then grade 2 is when you do moderate level of exercise like climbing up the stairs or climbing uphill, that is moderate level of exercises. Then grade 3 is when you do minimal level of exercise, like you just walk around for taking a bath or something like this, everyday normal activity you do, and you get dyspnea on that activity, that is grade 3. And when you start getting dyspnea at rest, that is grade 4. So whenever you will be seeing dyspnea in mitral stenosis, you will be always asked about the NYHA grading of the dyspnea. Okay. Then second common symptom is the palpitation, and this is a common signal for the atrial fibrillation. Okay. Now there are certain other symptoms which you usually consider symptoms, but they are rather complications of this disease getting worsened, like edema, ascites, hemoptysis, persistent cough, hoarseness of voice, orthopnea, platypnea, and all those things. that like blue, purplish discoloration of the face, that is known as mitral facies. We will be doing all these things, but they are mostly considered as a complication because of the worsening of the disease. Symptoms are usually here only two, that is dyspnea and palpitation. So we'll be doing those things later on in complication category. Now we talk about the signs. So here the signs, if you see the pulse is normal. If it is atrial fibrillation, then the pulse can be irregular, otherwise it is normal. BP is normal. It decreases in severe MS due to decrease in cardiac output. JVP is elevated in moderate MS. There can be found an A wave due to pulmonary hypertension and a V wave due to tricuspid regurgitation. Edema is seen in severe MS due to right ventricular failure, and then on inspection you can see increased JVP, and on palpation you can see the palpable P2. Now this S2 heart sound is of that only a P2 is a component. Okay, you have the pulmonary valve and the aortic valve both together produce the S2 sound, so the P2 is due to the pulmonary valve closure. Okay, so you can hear the palpable P2 and left sternal heave. Tapping apex can be seen here, and there is no cardiomegaly on palpation. On auscultation you will see that there is loud S1 which is followed by an opening snap. On S2 you can hear the loud palpable P2, but S3 and S4 are not heard here. Okay, a very important thing that comes now is murmur. So what kind of murmur you hear here? So there is a loud S1 which is followed with early diastolic opening snap, and that is followed by a mid diastolic murmur. This mid diastolic murmur word is very important. Now this mid diastolic murmur is low pitched. Second, it is rough and rumbling, heard at the apex, and best in expiration. So these are the few points about murmur which you need to know, and very characteristic line is given in Hutchinson's, that is there is a loud S1 which is followed by an opening snap, and that is followed by an mid diastolic murmur which is rough and rumbling. Okay, now let us talk about those second rank symptoms which are usually considered as complications. So these are edema, ascites. Now they will occur due to the right ventricular failure. When the right ventricle fails, that will lead to the accumulation in the whole body, and especially pedal edema you can see, and you will also get the ascites. Then hemoptysis occurs because of the increased LA pressure that leads to the rupture of the bronchial veins. Then there is persistent cough due to pulmonary venous congestion. Hoarseness of voice can be seen because of the dilated LA that will compress the recurrent laryngeal nerve passing over it, and that will lead to hoarseness of voice. This is known as Ortner syndrome. And otherwise you can also get the orthopnea, paroxysmal nocturnal dyspnea, and this is all due to increased LA pressure. You will also get a characteristic finding, that is purplish discoloration of the face, that is mitral facies, which is due to decreased cardiac output. So after doing those complications or second rank symptoms, now we come on to the investigations. The first investigation in any heart pathology you do is in ECG. On ECG you will find atrial fibrillation, and the two important finding is there, that is P mitral, which is due to left atrium hypertrophy, and P pulmonale, which is due to right atrium hypertrophy, as you can see on your screen. Okay, on chest x-ray you will see there is straightening of the left heart border, there is enlarged left atrium which is known as double shadow, there is widening of the carina, that is left main bronchus is lifted by the left atrium. Okay, and then there is backward displacement of the esophagus, and there is pulmonary congestion. All these things can be seen on an x-ray. And on transthoracic electrocardiogram you will see orifice area is less than 1 cm square in severe, pulmonary artery pressure more than 50 mm of Hg, again severe, associated MR and calcification and thrombus. This is all what you can see on transthoracic electrocardiogram. Okay, management is balloon valvotomy, mitral valvotomy, and mitral valve replacement. Medical management is done for some mild degree of problem, include systemic embolism, anticoagulants, atrial fibrillation is digoxin and beta blockers, pulmonary congestion you have the diuretic therapy, and the antibiotic prophylaxis, which was earlier recommended for infective endocarditis, is no longer routinely recommended. In surgical you have the mitral balloon valvotomy, that is after transeptal rupture the deflated balloon catheter is advanced across the interatrial septum, then across the mitral valve and into the left ventricle. Now the balloon is inflated stepwise within the mitral orifice so that this narrowing can be broadened, okay, and relief can be given. The last step is mitral valve replacement. When you have nothing left, so you have to do valve replacement. It is specially done when there is an associated MR. So this was the management. Thank you.